Good afternoon. It's my great pleasure to introduce Dr. Jan Watton, Associate Professor of Psychology and co-director of our neuroscience program, co-director of this conference, to introduce our next speaker.
Good afternoon, everyone. In the last 100 years or so, rigidly enforced boundaries between science and art, science and religion, science and music have just separated our view of humanity and our understanding of being human into very different realms. There was a concerted effort to remove emotion from anything that might be considered appropriate for scientific study, and even from our view of scientists themselves. As a consequence, our explanations of behaviour accurate, yet incomplete. They simply didn't reflect the richness of the human experience. Gradually, a new group of scientists started to explore the ideas of emotion, and they found that it was a key part of the puzzle. As Goethe said, science arose from poetry. When times change, the two can meet again at a higher level as friends. Bringing emotion back into science allows these different realms to meet again in our understanding of brain function. This is a great time to be a neuroscientist. The field is growing at an extraordinary rate. We have new tools and techniques to help us unravel and explore the brain. Well, Dr. Helen Mayberg was fascinated at a very early age with questions of brain function, and she wished she could see into the brain. Her timing was impeccable. Just as she was finishing medical school training, brand new techniques came about, allowing her to see into the brain, imaging techniques. She immediately saw the possibilities, saw the opportunity to answer her questions, grabbed that opportunity, ran with it, and now she's a leader in the field. These are her kinds of questions. How and where are emotions experienced in the brain? And how do the brains of patients with mood disorders differ from others? She wants to know how our brains produce emotional experiences, and she's developed the premier model to understand the brain's circuitry, to explain where emotion is in both healthy and disordered brains. Her studies have led to greater understanding of depression and new treatment options. Just a few years ago, Dr. Mayberg stunned the medical community when she and her colleagues used a technique, a targeted electrical stimulation called deep brain stimulation, to help relieve the symptoms of depression for people with severe and intractable depression. It was quite amazing, and she's going to tell us about that. Notably, Dr. Mayberg has been acclaimed both for her groundbreaking studies, but also, importantly, for her work to translate this into medically beneficial applications. She's published many, many articles in prestigious journals, and she's also been acknowledged by her colleagues with some extreme honours, and I have some listed here. For example, the Roche Senior Award for Translational Neuroscience, the Falcon Prize for Mood Disorders Research, the Arnold Pfeffer Prize, and the Raymond Adams Award. Dr. Mayberg is currently a professor of psychiatry and behavioural sciences and neurology, and the Dorothy C. Fuqua Chair of Psychiatric Neuroimaging and Therapeutics. As one of the field's leading thinkers, we are honoured to have Dr. Mayberg tell us about the current understanding of the neurobiology of moods and emotions at this Nobel Conference 47, The Brain and Being Human.
Well, it's really a pleasure to be here and to share this time with an intimate group of friends, as I see. I'm going to talk today about really mapping depression in the brain and how the ability to map an illness and sort of an ethereal illness has really led to a different way to conceptualize depression and actually lay foundation to how to treat it differently. I'm going to be talking quite a bit about the off-label use of medical devices, which means don't try this at home, but also that these are not approved yet for the use of treating patients. So consider everything I talk about today to be experimental. Some of the work has led to actual patents that have been picked up by industry, and the work I'll be describing is now going to be taken into full-scale clinical trials. And I do consult to companies that do this type of work. I think it's important to start, since we're going to talk about the brain, we're going to look at brain pictures, you're all going to become neuroanatomists by the time the hour is over, to actually just get into the head of someone who is ill. Because I think as we get into the third-person perspective to look at what's wrong with the brain and to look at the brain is to understand what the experience is and what we can learn from the experience. And as we heard about, poetry and science, William Styron, she'd rest in peace, was one of our fabulous writers, novelists, among many things. And in his depression, he described it eloquently in his book, Darkness Visible. And if you read what he says carefully, again, the metaphor is pertinent. The madness of depression, the antithesis of violence. What a oxymoron. A storm, but a storm of murk. Slowed down responses, near paralysis. Depressed patients aren't paralyzed, but the metaphor is they feel like they are. Psychic energy throttled down to zero. The next part is nearly immobilized, but in a trance of supreme discomfort. And I've color-coded it. You have the contradiction between paralysis but agitation. There's an anxious sense. The emotion is very bad, but it's an active emotional state. But people feel as though we're in a helpless stupor. Now, if you look historically, that's a contemporary view, but actually historically, the idea of a positive and active anguish was something that was first written by William James, again about his depression. A sort of psychic pain, a psychical neuralgia. You don't have a psyche that has pain. So again, the metaphor is very, very pertinent. But what he said very clearly was it was wholly unknown to normal life, meaning that unless you've been ill, you don't know what this feels like. And keep that in mind. This is not having a bad day. But Hippocrates, so far before, had actually also, I think, captured the essence of what this illness is, melancholia. If a fright or despondency lasts for a long time, it's a melancholic affliction. So first takeaway point is that depression is primarily about negative emotion and chronicity. Now, in contemporary times, we take the antiseptic point of view because we need to diagnose people, put them into categories, decide what disorder you have, because that actually, unlike in ancient times, we have treatments. We don't bloodlet. We don't look for, alleviating dark humors, black bile. We actually need diagnostic criteria. And in the Diagnostic Statistical Manual, for a major depressive episode, it's negative mood. But now it's actually not even clearly just about mood. It's decreased interest, decreased ability to experience pleasure, not just an active anguish. And then there's a laundry list of various symptoms: disturbance in sleep, appetite, your motor activity, energy levels, can't concentrate, don't feel good about yourself, and actually can feel as though you'd be better off dead. This is clinically significant distress. It impairs your functioning across the board. It's pervasive. It's present all the time, most of the time, for a minimum of a couple of weeks. And it affects really the whole body. So, this is what a major depressive episode is, and I want everyone to keep that in mind. And more for the point of, this is not just a rare disease and interesting kind of curiosity. This is wildly common. The numbers are that 17% of people will have a depressive episode at some point in their life, women more than men. It's the leading cause of years lived with disability above all others. It affects young people. And with that kind of discouraging point of view, the good news is that we have treatments. But the reality is that we have treatments, fabulous psychotherapy, cognitive behavioral therapy, a whole plethora of medications that have been tested and proven to be efficacious. The problem is we only get 40% at best of people well. Pretty lousy odds. Worse, about 10% of people will become resistant to treatment over time. And of those, about half will get better if you give them something as extreme as electroconvulsive shock therapy. But even if they get better, they won't stay well. So what's our problem? We don't know where in the brain it really is. We argue about what the diagnostic criteria are. Patients are all quite different, and we don't really have any good biomarkers to say you're definitely depressed. We don't have that lab test. We don't have that echocardiogram, EKG, things that we have in other branches of medicine. And we don't really have good animal models that kind of really capture it. And those that we have about kind of sad animals or animals that aren't interested in mates or in reward, it doesn't capture the fact that it's a recurrent illness. And it also doesn't capture resistance. So what do we want in medicine in this field? We want to get out of an episode as fast as possible. We want to maintain that effect and prevent relapse. And we want to get people the treatment that they need. So as we consider what would we want out of a new treatment, and what I'm going to describe is the idea that we just don't talk to patients or give them meds, but actually we're going to discuss whether or not it's appropriate, viable, plausible to actually have a place in the brain where you could put a precise wire and deliver a very minute amount of electricity to a very particular place. What would you need to know? Brain's a big place. You'd need to know, what is it you want to get better? I gave you a big list of symptoms. Where would you stimulate? Who should you stimulate? And what that requires is that we have some idea about the network in the brain, the choreography of brain areas that mediate these kinds of symptoms. We want to know what part of those brain areas or those brain networks are important to guiding the recovery. That'll help us set up what brain areas we'd like to stimulate, because it'll tell us what brain area might be most central. And then if we really can get down this list, what would be ways in which we could know who the right patients are, could know in advance? Well, it's not just, woke up from a dream, had this idea. I mean, what has been the facilitators to even think about this for a psychiatric disorder? It's been the availability of imaging, and it's been advances in neurosurgery, and it's actually been the experience in other neurological diseases. So what do I mean by that? Well, the prototype is Parkinson's disease, a neurological disorder that's associated with degeneration of this area of the brain in the substantia nigra, and is associated with loss of dopamine. And this picture over here is showing what a normal brain with a PET scan with the dopamine uptake in the basal ganglia in red, and what happens where part of that signal is gone in patients with Parkinson's. And in fact, the pathology to understanding the chemistry led to the idea that you could replace the dopamine, and actually that revolutionized the care of patients with Parkinson's disease. Well, drugs weren't developed until the 60s, and neurosurgeons had ways in which to treat the tremor of Parkinson's going back into the 1930s and 40s. And they knew that there were places in the brain that you could make very discrete lesions, even without the kind of sophisticated imaging that we have now, and you could stop and arrest tremor and certain of the other symptoms in Parkinson's. And there were three sort of areas in the brain that they could make these discrete ablative lesions. But it really wasn't until the 80s and 90s that scientists started to really define how do these different regions in the brain actually work together, why those regions in the brain. And people started to come up with circuit models based on physiology, working predominantly in non-human primates, to actually get the wiring diagram and the crosstalk and how does cells in area A talk to cells in area B, to understand why would dopamine in this, let's see how this works. No, the circling isn't going to work. How dopamine in this system could explain why the symptoms were gone, and also why would lesions in these different locations explain why symptoms were gone. And one could even look at the electrophysiology in areas of the brain to help guide where you made these lesions. And it took a clever neurosurgeon, as he was planning to actually make a lesion in the brain, in the thalamus to alleviate tremor, as he was listening for these electrical signals to know he was close to the right spot, would use small amounts of high-frequency stimulation right as he was about to make the lesion, and found that he could know he was in the right place by stimulating. And it occurred to him, why not use stimulation all the time instead of making a permanent hole in the brain? And the whole kind of modern field of functional neuromodulation kind of was started. It's not that this stimulating the brain wasn't done for pain or for other things, but this logic of know the circuit, know the target, how to use the electricity in a very local place. And that it wasn't just about that one brain region, but actually looking at oscillations or the way the brain networks are behaving, that one could then use the stimulation to see how the circuit was interrupted. And this whole field really has evolved, and to me, this was the model system that's been available for about 20 years that really was the prototype for thinking about, can we apply this logic to depression? Well, depression isn't exactly like Parkinson's disease. There's no pathology. It doesn't have those same kind of readouts. But we can start with the depressive episode, and we can work backwards with the idea that there must be some areas in the brain that are regulating negative mood, and that those sit in some sort of homeostasis, some kind of equilibrium, until which time that something destabilizes them. And the question is that there be many risks that leads to depression or makes people at risk for depression: genetics, family history, personality, insults early in life. There can be exogenous stressors, early life trauma, medical illnesses, but that somehow there's a dynamic that we can explore by starting from people who are depressed and working backwards. And I want to kind of set up the hypothesis, because we're going to have to accommodate these various types of depression, that if one buys that there's a set of networks in the brain that regulate mood, negative mood in particular, something sets them off. We all have experiences. Something happens and we know it's a negative mood. Most of the time, there's just been a life event and we distract ourselves, we look for a solution, and one can kind of see that, sometimes a bad day is just a bad day. And one can kind of bring oneself back to an equilibrium state. But if actually the trigger kind of persists, there's an arbitrary point of time in which we call it a major depressive episode, where all of those other symptoms come into play. And you have to ask yourself, the brain is a dynamic organ. It makes adaptive maneuvers. If you feel bad, you look for a distractor. And the question is the brain just doesn't necessarily lie there and take it. It actually tries to adapt. And in some ways, it's the various ways in which the brain adapts that may be leading to why different people express different kinds of symptoms. And maybe the way we ought to think about depression is, in fact, it's this system that doesn't self-correct. And if we take that point of view in mind, maybe the hypothesis is, if we can define the state of the brain, maybe not what insulted it to begin with, but what it's doing and what it's trying kind of incompletely to correct itself, we can match up the brain state to the treatment that will help it to recover. So how do we kind of start to think about that? Well, there have been many theories about emotions that, again, I'm a neurologist, so neurologists, when you ask, who first did something, it was some French neurologist in the 1800s. If you just answer that, you're usually right. And Broca kind of was one of the first to describe the great limbic lobe, the emotional brain, and it's a structure, the cingulate, that I'll be talking a lot about. It's a very large part of the brain. It wraps around from front to back, and it has various connections to many parts of the brain, but is thought to be the central arbitrator of looking for novelty and particularly negative experiences. And Papes, in the early 30s, actually better characterized the Papes circuit, the emotion circuit that we all kind of recognize as one of the first descriptors of how different brain areas talk to each other to regulate emotion. And even like in Parkinson's, surgeons had solutions, or at least plausible solutions, for people who are suffering from intractable psychiatric diseases. And before everybody gets shocked, just imagine in the 30s and 40s, there were no drugs. There was Freud. You can't talk to someone in this level of suffering. People were in asylums. People were locked down. People were put in insulin comas. People were hosed down, trying to do something to alleviate suffering. And people thought that if you blocked or disconnected connections of the limbic lobe to the thinking brain, you could help people from this suffering. And these are horrific in retrospect, lesions that were made in the brain to try to relieve suffering. And they were refined in the 60s and 70s to have very, very small and very strategic lesions in the brain to make these disconnections for obsessive compulsive disorder, for profound depression, for chronic pain. And so it was always a disconnection, disconnecting a circuit from area A to area B in some kind of wave your hands sort of way. Because in fact, while it was a disconnection, it wasn't really quite clear what you were disconnecting. Concept was there. Suffering was relieved in many cases, but not with any kind of systematic study, which is really the only real true criticism of what went on in the past, is that there was an evidence-based review and there was really a modest logic. So what became the way in which to look at depression circuits? How would you go about it rather than just being critical? Now that there is a contemporary way to start to study this, how would you do it? Well, the advent of imaging allowed that to happen, and Bob Robinson, one of my teachers at Hopkins, was one of the first to systematically really look at accidents of nature, people having strokes. And you might think that, well, sure, if you suddenly couldn't move an arm or a leg or couldn't speak, you'd be depressed too. But it turns out that most patients who have a stroke don't get depressed, but certain patients do. And as he started to study what damage to the brain was associated with developing depression, it turned out that having a stroke in the left part of your frontal lobe was more associated with depression than any other brain area. And that laid brick number one. And as the technology came online, people started to take depressed patients without strokes and said anything different about their brain. And Wayne Drevitz first reported that there was an area in the ventral part of the frontal lobe, deep in the frontal lobe, that was smaller in people who developed a depression than patients who did not. And that was followed by another study by Yvette Cholin that found that an area that seems to shrink in response to stress also was smaller volume, atrophic in people who were depressed. So there started to be other bricks in this puzzle, other pieces in this puzzle of where depression might be living. Some of the structural changes are reversible. The hippocampal atrophy, it can seem to be not as bad when people are treated. And the question is, well, what does this do to how the brain is actually working? So that led to being able to take advantage of new technology where you could actually map the brain in action. You just didn't take a static picture. You could actually look at the functioning of the brain in real time. These are old pictures. You can see ancient history. The students, you weren't born yet, so just humor me. This is a healthy blood flow SPECT scan. And you can see from the side view that, your brain activity is not red. This is a color rendition of the activity in your brain. And the color is relative, so more brain activity it's red, less brain activity it's blue or green. Background is black. And in depressed patients, and this is one example, but in groups of depressed patients, what you can see is that a large area of the frontal lobe, the cingulate, as it turns out, the temporal lobe, were underactive. They had low blood flow, they had low metabolism. We can start to look at this in 3 dimensions in different ways. Again, we don't cut someone's head off. This is just done in the computer to help you see the orientation. We're going to remove, like a lid, the top of the head here, and now we're going to look down on the brain, bird's eye view. This is now not one person, but an average of 25 healthy people compared to 25 depressed subjects. You literally, in the computer, subtract every voxel from every other voxel, and suddenly you start to see that there are areas of the brain that are different. So second take-home message is it's not just your frontal lobe, it's not just your left frontal lobe. We have changes in the frontal lobe, the cingulate, even in the parietal lobe. There's a network of brain areas. We don't think of it yet as a network, but there's a combination of brain regions that aren't working quite up to speed in people who are depressed compared to people who aren't. And this pattern was seen in unipolar depressed, bipolar depressed, obsessive-compulsive disorder and depressed. We saw it in Parkinson's disease patients depressed, Huntington's disease patients depressed, Alzheimer's disease patients depressed. If you were depressed, it didn't even seem to matter what illness you had this pattern. So step 3 in this is that, okay, brain isn't working well. What happens if you treat it? Does it go back to normal? And in a series of experiments, again, many of the experiments, I'm showing you slides because they're slides from my lab, but other people were doing similar kinds of studies at the same time. We found that if you treated people, and in this case on the left, the front view and the side view, that if you treated people and they went from depressed to recovered, we saw a recovery in that underactive frontal lobe. We corrected it. You can see it in red. But we started to see that there were other areas of the brain we didn't even know we should be paying attention to. They weren't abnormal to start, but with treatment, they turned down their activity. And I'll call your attention to what now is my preoccupation in the brain. This is called the subcallosal cingulate region, or Brodmann area 25. We'll call it area 25 for short. And area 25 wasn't abnormal to start, but it downregulated its activity with treatment. And the magnitude of how well the frontal lobe corrected and area 25 turned down determined how well people recovered from their depression. Well, at the same time, we said, well, what part of depression was getting better? The whole syndrome, any one part? We've got 2 brain areas. They do different kinds of things. So we did an experiment, and we basically took healthy people, and we threw them in a scanner, and we said, okay, we want you to think sad thoughts. What's your worst experience? Usually loss. A loved one, a pet, a sick relative, usually not a bad grade on a test. Usually real grief. People could conjure up over 10 minutes that sensation in the scanner, and we would compare neutral mood to extreme negative mood. People actually, if you let yourself do it, you actually can bring yourself to tears, and that's what we were using as our metric. Get into that state, lie there, and just experience it. Don't think sad thoughts, feel sad. And when people felt sad in that scanner, the biggest area of change in the brain was, again, this region, the subcallosal cingulate area 25. And it turned the frontal lobe off. And so when you think about it, when you suddenly are confronted with a situation that makes you feel bad, what happens? You turn inward. You stop actually thinking about things outside yourself. You've actually become a little disconnected. And that's what we saw in the brain in real time over 5 minutes. And you can actually superimpose all of the yellow circles, and the changes in the brain that go with depression recovery totally overlap the changes in the brain over 5 minutes. On the left, glucose metabolism in men. On the right, blood flow in women, 6 weeks versus 5 minutes. That we've suddenly got 2 areas of the brain that are talking to each other in a reciprocal fashion, and we're starting to converge on areas that might be important. So we started to study this, we started to collect these pieces, put them together in kind of a puzzle, have kind of a working network of the brain. This is not color-coded because I have that word color synesthesia. I'm both not creative and I don't have that. But that we found that we could get certain patterns of change with medication, but more importantly, we could get different patterns of change with cognitive behavioral therapy. And for all of you who may not know, drug and therapy work in a synergistic manner. They don't do the same thing in the brain. They complement one another. People always do better with both treatments. And so we now are getting this panoply of brain regions. And again, if you go back to the slide of what we need to go into the brain, which one of these places in the brain is actually the most important? Well, we started again, as you might imagine, to focus attention on this area 25. And why was that? When we kind of looked at our data, looked at the literature data, sad memory activates it, drugs that precipitate negative mood can activate it. And this was actually really in the region that Drevitz and his colleague had found had low volume, but also was abnormal in postmortem brain. We could see that the activity turned down with drugs like fluoxetine or Prozac or paroxetine, Paxil. We saw it turn down with other classes of drugs like venlafaxine, which is Effexor. We even saw that if you got well with a placebo pill, that area of the brain turned down its activity. So if you had a successful response to a medical intervention, that area of the brain turned down its activity. You could turn it down with magnetic stimulation applied to the scalp over the prefrontal cortex. You get changes in this region with electroconvulsive therapy. You can get changes in this region with successful vagus nerve stimulation, now an approved treatment. So our hypothesis is if you could not talk that region down, drug it down, or shock it down, maybe what you needed to do is it was stuck, and maybe if you could get in there in a very strategic kind of manner and actually modulate it directly, maybe you could affect change. So what we hypothesized based on what we knew from Parkinson's disease, well, we had our blob, I kind of know the general vicinity of where we want to go. If we look at the anatomy of the brain, so this is an MRI of the brain. People do not have those colored arrows in their brain, but this is a simulation of if you follow the different colored arrows, you can actually see the connections on the anatomical image of what would happen if you had an electrode right in that place. And if you look at our circuit model, area 25 now is in the central position, and actually you can trace in the brain and make predictions that you could impact this circuit more broadly. So where is this for real if you're going to have to get to this part of the brain by going into the brain? So here's from an atlas. This is a non-living brain, but a slice through our surgical area of interest. And we can come down through the top of the brain, come down with an electrode, and actually target area 25 and the white matter connections adjacent to it. So our focus was to say, let's look at treatment-resistant patients. And what does that mean? That means people that just did decide they don't like taking a pill, but people who have been unable to respond or have stopped responding in most cases to the available treatments. So what does that really mean when you kind of really think about it? To be treatment-resistant, every patient you find when you talk to anybody, and anyone in the audience, because 10% of you at this point in time could have a major depressive episode. No one can imagine you could ever be out of that state. And there's something so mysterious about the idea that you become unable to imagine yourself into a future when you're not well. But then when you're better, you are well. And again, William Styron, who responded very well to antidepressant treatment, described the idea that pain is unrelenting. Faith in deliverance, the ultimate restoration, is absent. That hopelessness, that's what's so overwhelming to patients. The idea that no matter what I do, nothing can help me. Well, if that's how someone who ends up getting well sounds, Just imagine that over months, years, that's the state that you're in. And so that is the target audience, the target patient population that we sought out to embark on this really whimsical, you could say, need to know as an experimentalist. What would happen if, could you tune Area 25 directly? Treatment-resistant patients, a minimum of a year in the current episode, functionally disabled, and actually having failed at least 4 treatments, including electroconvulsive therapy. So what actually is this? I think it's important because when you just talk about something and use words, the reality of this is brain surgery. Patients with a mental illness are allowing neurosurgeons to make an opening in their brain and place something in there. And Dr. Donahue's going to be talking about something related tomorrow. And I think it's important to realize the courage, but actually the responsibility that we have as experimentalists to actually take our ideas into the clinic and what we do. So this is a small battery, just like a pacemaker battery. And this is the wire, and you can tell by, these aren't like miniature hands. I mean, this is a small wire, like a piece of angel hair pasta. It's about 1 millimeter in diameter. And at the end of it, it has 4 contacts. It goes over the span of about 1 centimeter. And basically, we're going to have to get this deep into the brain. And how do we do that? Well, we attach this kind of frightening-looking device. This is called the stereotactic frame that neurosurgeons use routinely. And this is actually attached to the skull, and this becomes the conduit between the picture of the brain in 3-dimensional space and the surgeon and his electrode. The patient is then taken to the MRI, and we can then collect pictures that are reconstructed in 3-dimensional space, and the surgeon and the team can plan precisely the angle, location, depth, trajectory, can look at where blood vessels are, how to drive to make a plan to go into the brain precisely where you want to put it. Patient is brought to the operating room. They're now fitted in their frame into this contraption that allows the surgeon to basically, with coordinates, decide where in the brain they're going. And while we're recording, this is a simulation, but actually we're listening as you move the wire deeper and deeper into the brain. We can listen to the cells in the brain and confirm that where we think we're going to be is where we are because of the difference between white matter, the connection cables don't really have a lot of cells, and the gray matter adjacent do, and we can plan this. We do this under local anesthesia, patients awake. And we then are going to have the patient awake and are going to test them pretty much to make sure, at least we thought, to make sure that nothing bad happens, because no one had ever put a wire and stimulated in this particular area of the brain. So this was new. So the first thing we did, the patient's awake, the team's all there, the electrode's in place, the patient is now informed after 3 hours we're going to start stimulating. And we had kind of anticipated, because no depression treatment ever works right away. It takes several weeks. Maybe in the first week you start to notice a little bit. This was safety. Can we do this safely? Maybe something bad's going to happen. And much to our surprise, first patient tested the first contact, nothing. Tested the second contact, and suddenly patient says, I don't know if you just did anything, but I suddenly just feel a sense of calm. She started to try to describe it, had a lot of trouble describing it, used metaphors. It's as if it's the first day of spring and I looked outside and the crocus are coming out. And I'm thinking, we've hit some memory area like Penfield did, and there's a representation of the flowers. And she goes, no, I'm not seeing flowers. Turned out she was a gardener. To her, that sense of renewal, there was a sensation that seemed familiar of that first day of spring coming out in Toronto, where, and you all can relate in Minnesota, that first flower, thank God, winter's over. That was the first thing she had to report. Different patients described different things. It was always a state of the body, a lifting, less heavy, less void, less distress. it was as if the distress had sort of gone away, but in a very subtle way. This was followed as patients, you could see it on their face, kind of getting the idea that something was happening, but they weren't really sure what. They became more interested in the operating room. They started talking more. They used more words per sentence. It's like the gain just came on in patients. Some of them said the most wild things. They thought the room looked brighter. And again, we were talking with when Dr. Ramachandran was saying, depression, what is it? Things are gray, things are blue. What would it mean to have the color? Is that metaphorical? Is that real? Were we in some circuit? And it just was like your attention to the environment had changed. And the good news is like nothing bad happened. Either this phenomena of this lifting happened or nothing happened. And we saw it at some contacts, but not others. So close together were these stimulation sites. And if it was present, we used it for where we would do the chronic stimulation, but it didn't really seem to make a difference if people got better or not, so we just thought it was interesting. Well, the real proof came by actually taking these first 6 patients and treating them over 6 months. We kind of experimented to figure out which contact, which exact settings, but it really came down to it. We used what they used for Parkinson's disease. They did high-frequency stimulation and interrupted the Parkinson's system. We used high-frequency stimulation, and we got this effect, and that's what we used. And we treated people chronically over 6 months, and what we found is 4 out of the 6 patients didn't just get better, they were nearly well. And as we did our PET scans, we had found that these patients had had overactive 25 and low activity in the frontal lobe. And as we looked at the responders over 6 months, it had fulfilled our hypothesis. We'd turned down area 25, but we'd also affected changes in the circuit every place that area 25 talked to. Sorry, I'm being attacked by critter. Okay. So again, that gave us impetus to extend our studies. 6 people, 4 out of 6, that's good, but it's kind of a small group, sorry. So we expanded the study to 20 subjects. Here shows you the change in the depression severity rating over time, starting at a 25, dropping down in half in the first several months, and a sustained effect over time. We actually have just published on the long-term outcome in these 20 subjects outside of 3 years. And pretty much if you got better, you stayed better. And so, but this is with continued stimulation. We don't lose the effect as long as you keep it on. There are no late developing side effects. Cognition isn't impaired, so there doesn't seem to be a price you pay to have the stimulation on all the time, which makes no sense to me, but it is what it is. People have gone back to meaningful activities. But before everybody, jumps at the chance, 2 patients committed suicide, and not because they were non-responders. That first patient that I described, that I have such memories of and who was so helpful to what she did, 6.5 years out, was found dead. So again, this is a malignant disease. Everyone can be alarmed, but in cancer, 5-year survival is pretty good. This was 6.5 years of sustained higher functioning as opposed to being in bed, incapacitated. But again, to remember, this is a malignant disease and an aggressive approach. Other brain targets have been studied, which tells us, just like with the lesions, different areas of the brain may be appropriate. Just like in Parkinson's, different areas of the brain may alleviate the intractable state, but may have slightly different side effects, may have biases to affect certain symptoms more than others. But overall, the early data from the different targets in the brain is similar kinds of response. So suddenly, for people where we have nothing to offer them, they have some hope. So what's the next steps? It's up to the companies. They need to do large-scale controlled clinical trials, people to be operated on, not know if they're getting active stimulation or sham stimulation, and do like you do for any treatment. Let the data tell us if this really works. But from an experimental point of view, we want to know, why didn't everybody get better? How can we make people better that didn't do as well? Did we do something wrong? Maybe we need to actually identify biomarkers that will help us predict. And now that we actually have some toehold into important areas in the brain, what actually did we do in the brain? Instead of Larry, as Dr. Young talked about, animal models moving to the clinic, here we have the clinic, and this is the idea of reverse translational research. You know, how can we actually get an idea of what's going on going in the opposite direction? So our strategy at Emory, because the work I described was all done in Toronto, was to actually replicate this and to look at not just major depression, unipolar depression, but to see if actually bipolar patients might be helped with this. Because bipolar depression, and particularly bipolar type 2 depression, is notorious for being very hard to treat, and that medications often flip people into mania. So my team at Emory embarked on a new study, and it's in press now. Very similar response to what we saw in Toronto. There was a change over time. We did sham stimulation for a month, and there was a modest drop in the score, but not anything clinically meaningful. We saw no difference between the response characteristics of the people with bipolar as the people with unipolar. We, at no setting, even in people who weren't doing well, if we turned up the current, we could not make people manic. A very, very interesting and important observation, that positive mood and mania is not on a continuum with negative mood, at least as we're looking at it. And we actually found, if you look at these numbers, that it wasn't as good for the remission at 6 months as we had in Toronto, but by keeping the stimulation on, we actually do much better as we go off over time. So there's something about this where the effect grows with having the stimulation on. It isn't an all or none. So then the question is, well, can you turn it off? What happens if maybe you kind of fix the brain, if you're kind of well long enough? And in our first 3 subjects, the plan had been for all 17, that we turned the stimulation on, the group's scores went down, and here at 6 months, they were told, we might leave you on, we might turn you off. And slowly over 2 weeks, people started to notice they were slow, not sad. They didn't feel like doing anything when they woke up. And as we watched them over 2 weeks, we had recurrence of symptoms. Nothing as bad as it had been initially. We turned it back on and actually were quite concerned because it took as long to regain the effect as it had at the beginning. And we actually stopped that experiment and said, looks like you really need to leave it on. And even in Toronto, you know, patients out 5 years going to get a battery replacement, they get the dwindles. And so there's something about we're maintaining the brain in a new state, but we're not fixing it. So the question is why don't all patients get well? I'm telling you the story, this is very exciting. We've got some optimistic first clues, but when you go from people can't get well on anything to get 60% of people well, all anybody cares about then is, well, what'd you do wrong? So the first question is blame it on the surgeons. Well, we can't blame it on the surgeons because the surgeons can very precisely put it exactly where we want it. And if you look at where the active contact that we were stimulating was between the responders and non-responders, it's exactly in the same place. So it's not just where in the brain. That's not informative. So the question is back to the network. This isn't about Area 25. Area 25 somehow seems to be at this funny intersection, talking to the frontal lobe, talking to the brainstem, talking to the hypothalamus. It's an intersection. And the question is where is the traffic going? And which road is most important than others? And we can use imaging, a different kind of imaging, to ask that. So we can look back at our possible effects on the roadways, and we can actually ask, with a technology called tractography, diffusion tensor imaging, what are the actual true tracks that stimulation and a location would be impacting? And we can actually look, and this orange thing is the electrode as viewed from a CT scan, colored orange for cuteness factor. But that actually looking at what would be the tracks you got into if you stimulated at contact 3 versus contact 2, and everybody can see that the color maps are different. We're getting into different roadways by stimulating within a couple of millimeters of each other. And so small anatomical differences can translate into significant physiological differences. That's the hypothesis. So how do we test that? Well, we know how to test it. We know this might be true because we go back to Parkinson's. It was a very famous story back from '99. They were implanting in Parkinson's patients to hit the subthalamic nucleus in red, and they put the electrode a little deep, and they got into dopamine-rich areas in the substantia nigra. And when they turned the electricity on, this elderly Parkinson's lady, who never had been depressed, suddenly became catastrophically overwhelmed. You can see I'm falling down in my head. This is translated from the French. I no longer wish to live. I mean, she really was crying. You can see the expression on her face over seconds. Turned it off. There was almost a rebound jocularity. I mean, my read was that she started laughing, started flirting with the doctor, kind of playing with his tie. That there was this rebound, almost kind of mood shift. We had a similar case in Toronto, and the phenomenology was a little different. This was a woman that knew what depression was. She says this was like this agonizing apathy. I mean, to imagine someone saying, if you held a gun up to my head right this moment, I just wouldn't care. Go ahead, pull the trigger. And we actually caught that in real time the next day with fMRI. And as you can see that when we turned on the electrode and she had this phenomena, we turned the frontal lobe off. I want you to kind of pay attention to that area of the frontal lobe because now we're going back to our patients and we're revisiting what was that acute phenomena in the operating room where someone said things like, I've suddenly shifted from a state of all-consuming internal focus to realize there are things to do. Or my most favorite quote of all time, a man who had 5 children, and his idea of the noise of depression was, it's as though I've been locked in a room and can't get out with 10 screaming children, and whatever you just did, the kids just left the building. What is that in the brain? Because when you have that, it predicts a rapid improvement in your depression. So what we did is we went back to the track maps. We said, which contact gave us the behavioral effect in people who had it? Let's compare that track map to the one right before where they said nothing. And compare that within each person. The green map is when you got a behavioral effect, the blue map is when you didn't. And if you subtract the 2 maps, you have to get into that part of the frontal lobe or you don't get the effect. And we've actually subsequently looked at the fact that if you're a rapid responder, well within 2 months, compared to it takes you longer, the way and the roadway that you need to get into to get better faster is into that area of the frontal lobe, the very area that that Parkinson's patient turned off when they got into the wrong spot and turned that area off. So we start to see that this is not just area 25, it's in some very other specific places. And I just kind of I have another couple of minutes, to kind of show you that this idea of getting deep, each patient is so precious, both as a patient, but also as an experimentalist. Unlike being able to do in a clinical trial hundreds, thousands, genetics, they're not happy unless they have 50,000 samples. Each patient, for Dr. Donahue and I, is an opportunity to learn something. So we had a patient, it was patient number 24 in Atlanta, and she was the absolutely ideal patient. She should have gotten well. There was everything that we knew, we would have predicted that she would have done well. We implanted her, and as you can see, the electrode, the bottom is there. And as we kind of learned over the 6 months, as she had just a partial response, then actually her electrode was kind of not quite as deep in the brain. This was an example, maybe it was a surgeon's fault. And so we talked to her about actually repeating the surgery because we had every reason to believe from those track maps that we weren't getting the track she needed to get better. So we brought her back to the operating room, had her awake, replaced the electrode, and as you can see, it's deeper in the brain. And the arrow points to actually a contact that when we hit that, she had a dramatic behavioral change in the operating room. And what you can see what happened, the first part of this graph is what happened in the first surgery. There's a modest drop in her depression scores. We got to the endpoint. She had about a 35% drop in her score, and what she said I was just trying to be hopeful. And she got to that kind of, arbitrary point in the experiment, and she immediately actually sort of really felt terrible that she hadn't done well, and we operated on her a little bit later. And as you can see, is when we changed the contact and had a better place of stimulation, she had a fairly rapid improvement now. And in fact, she went at 6 months, 7 months was in remission, and 8 months applied for her first job and has a new job. So again, the fact that she has a more enriched life is the best news. The fact that we were able to make that educated decision based on the data is the better news. So what do we want to do? We want to get to where, not that we have to re-implant people, but is there a marker that will tell us in advance what might predict that patients might be appropriate for this? And we can use a third kind of imaging now, functional MRI. And these are functional MRI maps comparing our DBS patients to age and gender-matched healthy volunteers. And if you look to compare the maps of these patients, what you see is that there's our friend area 25 is over-connected in the brain, and here our friend in the frontal lobe that we need to reach is underconnected. And that the magnitude of predicting before you ever treat how well you're going to do at 6 months is predicated on how abnormally connected area 25 is. So after all is said and done, going back to those first experiments of sadness and Prozac treatment back in the late 90s, we're revisiting the fact that our best educated decision of where to go is actually substantiated by these patients' brains themselves. So I just want to kind of end with the idea that, I don't want to leave you with the idea that recovery just needs a stimulator. Otherwise, I'd be very busy. Actually, the surgeon would be very busy. Recovery is way more than a stimulator. And I think that what we've learned is, as we knew when we started doing experiments with cognitive therapy, that no treatment, whether it's a medication, a drug, a stimulator, that's all you need. That in fact, you have to really reframe for patients their expectation about what it is to be well. And what's really interesting about these patients is once you actually allow the brain to get on with itself, you have to retrain it. What do you do if you haven't worked in 5 years? Where do you start? I mean, look what happens now. If you haven't had a job in 2 months, you can't get one. What do you do if you haven't worked in 5 years? Or like that last patient, haven't worked in 14 years. Where do you start? I think the other thing is about changing expectations over time. When you're intractably ill, you just want someone to take pain away. Once you're actually no longer in pain, now you actually have new priorities. Surgeon isn't going to do that. The psychopharmacologist isn't going to do that. People need rehab, just like when you get a new hip. Want to run the marathon? The orthopedic surgeon can give you a new hip. You need a trainer. So we have to think about this in a holistic plan, which really gets us back to the whole meaning and intent of this conference. It's, the brain and being human. I mean, this isn't about cyborgs. This is about how do you make the brain the best it can be, and sometimes it needs help. Patients who have diabetes need help. They need insulin. It doesn't change their pancreas. It enables them to live a full life. Same with brain stimulation, it turns out. And as patient 5 let us know very clearly, look, you didn't give me anything. But what he meant was, no, you actually took something away. The heavy, sinking feeling, he actually felt constantly like he was swimming in quicksand, and if he didn't keep moving somehow, he would drown. That went away immediately in the operating room. Step 1, system reset. And then what he said, I think, was really, really profound. Look, now what I know is that I'm trying to climb a mountain, and I've managed to reach a ledge, and I'm looking up, and I can look down and see how far I've been now. I couldn't even tell where was the bottom before. Now I'm looking up, and I realize I've got quite a ways to climb, but I actually can assist in the climb. And that really gets into plasticity. Now that the brain is listening, how do you enable it? And I think that's where rehabilitation is important, and that's something that we have to think about. And as the patient I told you about with the reimplantation said, DBS doesn't make it easy, it just makes it possible, and now my efforts have impact. And I think, our scientific job is actually trying to figure out how to optimize that for our patients. So to end, this is my team. This is my various teams. I'm old, so you can tell how old I am, although I started college when I was 6. And I do want to acknowledge Andres Lozano here, my partner in crime in Toronto, fabulous functional neurosurgeon who had the courage to take my ideas into the operating room, and Sid Kennedy, our psychiatry colleague in Toronto, and now my team here, Paul Holtzheimer, who's now subsequently moved to Dartmouth, but Bob Gross, who continues the charge at Emory, and I have a fabulous team of students and residents and postdocs and investigators to look at very many aspects out of this so that we can bring this scientifically to its highest level. Thank you.
Thank you, Professor Mayberg, for that interesting and hopeful presentation. At this point, we'll gather our panel again for the question and answer period. So we'll try to do that pretty quickly and get restarted with the question and answer in about 2 or 3 minutes. Thanks.
That was great. That was so encouraging. I feel so good about being a neuroscientist now.
Okay, we're going to get started. And same format. We'll first have our invited guests ask some questions and contribute some comments, and then we'll go to questions from the audience. Thank you. Nancy, Dr. Murphy.
Since you are working exclusively with treatment-resistant patients, have you done any speculation about what this might mean for the more, I guess you might call it the more common variety of depression, especially an explanation for why the use of antidepressants plus therapy, sort of working from top down and bottom up, works better than either of those alone?
Well, I think that, one way to speculate is that I think that this kind of work, even if this continues to do well, this is not, as I like to say, getting your nails done. I mean, this is brain surgery, and for neurosurgeons, this is actually not trivial brain surgery, but reasonably straightforward. It's an easier operation than many. But I think that it points to what is special about these regions that are critical. It actually points to an exploration of the pharmacology of what actually is common, either genetically or biochemically, about those areas that are affected. And one can start to engineer, if you will, pharmacologic agents that might represent what's happening by the stimulation. So I think it kind of constrains the field, if the exploratory field, if you will, as to where one might look. From the point of view of, and I think that with other treatments, you can tune this kind of network or get it, change the bandwidth in a way that they actually have more dynamic range to start. So I think that the issue about the complementariness of drug and therapy, what I didn't show is, for the sake of time, is that with therapy, a real target of change is in cortex, and actually in those same areas of the medial frontal cortex, so that you can come at that system kind of top down, and that you can actually get changes and sort of paradoxically in the opposite direction in area 25 with therapy. And I think it's that this isn't about should it be up or down, even though the methodology kind of drew us in that direction. It was, Parkinson's disease, what was it? Stimulation at high frequency equals ablation. So if I want an area to turn down, I should use high frequency. Well, by the time we got through the first round of experiments, the people studying mechanisms of DBS said, oh, no, it's not like stimulation is interruption, it's actually excitation. Well, that doesn't really work really well for my theory. You know, and quite frankly, I mean, people don't believe me, but if I actually knew what was known now about the mechanism of brain stimulation, I would not have felt in the position, based on what I knew from my PET scan findings, to proceed. So in sort